Hello everyone, I'm Alex.
I'm Jackie.
I'm Simon. Today we are going to present to you the critical illness, diabetes ketoacidosis. This is our poster, and we will look into it one by one. Diabetes has been the 11th leading cause of death in Hong Kong, resulting in 661 registered deaths in 2022. One of the common reasons for diabetes patients to be hospitalized is diabetic ketoacidosis. Diabetic ketoacidosis, DKA, is a clinical emergency resulting from insulin insufficiency. DKA accounts for 14% of all hospital admissions with DM, and 16% of DM patients passed away due to it. Insulin non-compliance, infections such as pneumonia and UTI, myocardial infarctions, and PE are some of the common precipitating factors for this emergency. It is characterized by three elements, with a blood glucose concentration more than 11.0 millimole per liter, or history of diabetes, blood ketone concentration more than 3.0 millimole per liter, or ketonuria, which could be identified by a urine multisticks with more than 2 in ketone, and also blood acidosis as evidenced by blood pH value lower than 7.3 and or less than 15.0 millimole per liter blood bicarbonate concentration. It is more commonly seen in people with type 1 DM diagnosis, but also be documented to be found in DM type 2 patients. Timely management could prevent DKA patients from getting into diabetic coma or even death. Therefore, it is crucial to understand the workflow of DKA treatment once it is diagnosed. Jackie will now show us the DKA management in Hong Kong.
In Hong Kong, DKA treatment consists of four major parts, including aggressive fluid replacement, insulin therapy, potassium replacement, and treatment of the precipitate factors. In PWH, DKA is first treated with aggressive fluid replacement, with around 2 liters in the first 4 hours once DKA is diagnosed, followed by a slower fluid infusion rate. Normal saline is the first line of choice due to its effect on restoring intravascular volume and perfusion and ketone clearance. The fluid therapy treatment is well supported by the foreign studies, which also share the same field on using normal saline over colloid solution due to its widespread availability and low cost. Yet, study has also hinted that caution on hypercholesterolemia has to be aware of prolonged use of normal saline. Insulin therapy is achieved by using a continuous insulin infusion with an average initial rate of around 0.1 U per kg per hour, with not exceeding 10 U per hour for patients weighing over 70 kilogram. PWH ICU has a sliding scale for its insulin infusion, which allows physicians and nurses to titrate the infusion rate according to the latest blood glucose level. For example, if the current blood glucose is 19.0, the insulin infusion rate would be 2.5 U per hour. If the blood glucose level drops to 12.4 mO millimole per liter in the next hour, the infusion rate should be changed to 1.5 U per hour. Close monitoring of blood glucose is needed so as to titrate the insulin infusion rate timely. If poor improvement on blood glucose restoration is seen, the infusion scale may be changed to one with higher initial rates, as shown in the table. For example, if the blood glucose remains more than 22.0 millimole per liter for hours under the initial insulin infusion scale for 3.0 U per hour. Patients are considered to be non-reactive to the current insulin infusion scale. Doctors would be informed and they would decide to change the initial rate to a higher scale. A 5.0 initial rate would be used and a new sliding scale would be adopted. Potassium replacement is also emphasized due to the intracellular shift of potassium alongside with glucose under the effect of insulin. So in QEH, the hospital also shares similar views with PWH in tackling DKA with the use of fluid replacement and insulin infusion. So we'll pass on to Alex for the next part.
Okay, thank you, Jackie. From the above, we could see that DKA treatment is well established in Hong Kong with very strong research support. Yet they are mostly physician-driven with the rate changed by doctor. A recent study suggested the use of a nurse-driven insulin infusion rate calculator, which allows nurses to alter the insulin rate according to the blood glucose level. To use this calculator, nurses are required to input the previous and the latest blood glucose level and the current insulin dosing value. The system will then calculate the insulin infusion rate based on the algorithm shown. When the patient has a blood glucose level higher than 250 mg per deciliter and the change of blood glucose level more than 200 mg per deciliter is detected, the calculator would alter the infusion rate by a reduction of 50%. However, if the change of blood glucose level is smaller than 50 mg per deciliter, the insulin infusion rate would be suggested to be increased by 50%. For example, if the blood glucose level was 400 mg per deciliter previously and 350 mg per deciliter for now, the current insulin infusion rate is 3 units per hour. The calculator will calculate the new infusion rate of 4.5 units per hour, and the nurse would simply change the rate accordingly. This easy-to-use calculator offers nurses to have autonomy on the alteration of insulin infusion rate. Lee and the others in 2020 has shown that DKA resolution time has no difference among groups of using or without the use of the nurse-driven infusion calculator. While cases of hypoglycemia and severe hypoglycemia are significantly reduced from 46.2% to 13.6%. The current Hong Kong practice of the use of a sliding scale of insulin infusion also allows nurses to change the rate according to the latest blood glucose level. Yet it could not target on the change of the blood glucose level. Under current practice, if the blood glucose level remains more or less the same over the hours, no change of infusion rate will be made until the physicians are informed and ordered to change the infusion rate scale. In other words, proper treatment would be delayed due to the unavailability of the physicians. However, if the calculator is put in use, the infusion rate could be altered according to the needs of the patients by the nurses. Another study also supports the use of nurse-driven management, which shows similar results if the treatment is nurse-centered. Lengths of hospitalization may be also reduced, which in other words, earlier discharge from ICU and hospital, resulting in better utilization of public resources and reduce the costs.
From the above, we could see that the nurse-driven insulin infusion calculator always the current Hong Kong practice. Yet, we believe that further study and training has to be carried out before implementation in Hong Kong. First, since the calculator was designed for non-Chinese, adjustment may be needed for Hong Kongers' use. Moreover, exclusion criteria for the use of this calculator has to be set up. For DKA patients with multiple coexisting acute illnesses, such as end-stage renal disease, studies have shown that end-stage renal patients suffering from DKA may require dialysis. But simultaneous ultrafiltration and insulin infusion could cause a rapid depletion in intravascular volume and hypotension. Caution has to be made when handling these patients, and the nurse-driven insulin infusion protocol may not be considered to be suitable. Guidelines for illness excluding out of the use of the calculator has to be clearly stated to prevent severe complications. Training has to be made to nursing staff before implementation in Hong Kong, educating them on the correct use of the calculator and when to use and not to use the calculator. Return demonstration is also needed to evaluate the nurse's competency of using the new tool as to minimize mistakes. This is the end of our presentation. Thank you.